The 7-year outcome data for the lumbar disc replacement was amazing, though, because what they showed was if you got a 2-level disc replacement compared to a 2-level fusion, the fused patients were 300% more likely to develop another problem. Not 30%, not 100%, 300%. And so, and that's level 1 data. That's the best data we have. And so for me, that's very compelling.
Welcome back to the Spine Pod. We are in St. Louis. We made it through a tornado.
Amazing.
And we got to sit down with Dr. Kevin Rutz. And this was such a fun episode, especially just because we made it here safely.
That is an exciting aspect. And for him to join us after a full OR day was a lot of fun too. But he's a provider that truly excels in application of motion preservation. I mean, he's done 2,000 disc replacements over his 25-year career. Mm-hmm. That's incredible. And I think that, that lends him the ability to be able to pick and choose and find the right patients and get good outcomes. It's really impressive when you find surgeons like that.
I agree. Something that I've really loved over the last year sitting down and doing this podcast is finding more and more doctors like Dr. Rutz who can say, I specialize in motion preservation. I do disc replacements every day, every week, and they understand the nuances of what that means and being able to provide that information to patients and other surgeons who are curious in doing disc replacement, curious in motion preservation, like the learning curve. Getting to hear from people like Dr. Rutz is so valuable. And so this episode is just a really exciting one for that reason.
Well, he goes through his timeline of the different cervical discs he used over time and why he used each one and what he learned from each one. I think there's so much value in that because then he can tell when a patient walks in and says, am I a candidate for this? Or I was told I need a fusion. What options do I have? He can tell you if you're going to be a good motion preservation candidate, right? And then on top of that, he said 70% of the patients that are told that they need fusion can go get a motion preserving device.
70%.
That's incredible. Yeah. That's absolutely amazing. So he's helping those patients find better options, but he can do it because he's been through it. He's seen the outcomes. He's seen the technologies, and he can give them advice on that.
Absolutely. He has so many great stories. He is a doctor that really knows how to talk to the patient too in that perspective. So I think we should let him get into it.
Let's jump right in.
Enjoy this episode with Dr. Kevin Rutz.
Today, we're joined by Dr. Kevin Rutz. Thanks for joining us today.
Thank you. Thanks for having me.
It's a pleasure. We just got to live through a tornado warning, so that was fun.
We did. Right before getting here, we got to spend some time in the back of a grocery store in the freezer. But we're so glad we made it here. We get to chat with you.
Yes,
we made it. Well, this is awesome. We're here at your practice, beautiful place, orthopedic specialist of St. Louis. And you have a ton of experience in the space and what we care about, which is motion preservation. And so we want to hear a lot of your stories today. I mean, this is incredible because you yourself have done over 2,000 disc replacements, both cervical and lumbar. And those are the people that patients need to hear about, is those stories and how to find the right disc and how to rehab those discs and when to put them in and how to find the right patients. We've heard tons and tons of really cool stories about how surgeons got into medicine. How did you always know you were going to be go into medicine, or how was that for you?
So my family, my father was an anesthesiologist. My mother was a OR circulating nurse. And my dad, when he was little, the missionaries would come back from Africa and he'd hear their stories and they'd show the slideshows, little Kodachromes. And my dad wanted to be a foreign medical missionary. So he went to medical school with that intent. And then when the time came, there was a group in San Antonio that would go into small villages in Mexico. And in the summer and during Christmas, just like here, there's no school. And so they'd have these cement schoolrooms with slat windows. And for about 30 years of my parents' life, for 2 weeks in the summer and 1 week at Christmas, they would go down into Mexico, set up a MASH Army style operating room. So there'd be 3 beds, and my dad would do anesthesia and other people would volunteer and come. And the hard part about those sort of trips is not just getting down there or getting people to go, but having all the equipment you need to do surgery, starting with a cement room. And so back in the day, my dad, when there'd be leftover stuff on the operating table that wasn't used, the nurses would throw it in a bag. My dad would bring it home. My mom would make new surgical packs, putting things together. They'd take it back to Methodist Hospital in San Antonio, who for free would re-sterilize it. And so in a 2-week trip, they do 150 surgeries.
Wow.
And hernias, hysterectomies, cleft palates, things like that. And so when I was in high school, I would go on those trips, and I would work in the OR. And so it's kind of I would scrub instruments. I would carry patients on gurneys, like with our hands. And then I got to scrub in on some abdominal cases, and I thought, this is cool. And my brother absolutely could not stand the whole idea of being in there. And so anyways, when I got done with high school and I went to undergrad, I remember when my dad dropped me off, he said, Kevin, you're going to have to get pretty good grades. He says, you need to get mostly A's and not very many B's. So you kind of need to hit it hard now. And I really did take that to heart because I didn't know what else I wanted to do. So I went to undergrad at Baylor University, where I met my wife. And I was pretty nerdy, hit it pretty intense. And then I was lucky enough to get into Baylor College of Medicine and in Houston. And my wife, she wanted to go to law school, so she went to University of Houston Law School, and which is great when you're both students because you're both studying all the time, so you're not like missing out on doing things because you're both studying all the time. And then when I was at Baylor College of Medicine doing my general surgery rotation, which is what I thought I wanted to be, I realized like a lot of these patients are super sick and they want to die, and I just didn't like it that much. And then people kept asking me if I was going into orthopedic surgery, and I didn't really know what it was. And the stereotype back then of the orthopedic surgeon was sort of the ex-high school athlete that was good at taking tests. So back then I used to lift weights a lot and I had that look. And so then when I rotated on orthopedics, I was like, I found my people. And then what really sold me on it was hip and knee replacement. When I got done with medical school, I was like, I want to be a hip and knee replacement surgeon. That is the most satisfying cases we do. I mean, it was just really cool. And so then when I go on to residency, and what I realized was I kind of liked everything. And most orthopedic surgeons don't like spine patients or spine surgery, meaning that they'll say, well, the surgery's cool, but you have a lot of whining and complaining in clinic. There's a lot of people with back pain that's taken over their life, and it's not really a surgical problem sometimes. And it's harder to get a good outcome with spine surgery compared to some other surgeries. So you go in and go to the clinic where you're seeing the total hip and total knee patients, and they're just loving you. They're bringing you gifts and they're happy. And someone just had a big back fusion back then, and they're coming in, they're still hurting. And so I kind of realized that doesn't bother me. It's all the same to me. And my wife and I didn't have kids. So I was like, I can do a spine fellowship. It only takes a year. And she was like, okay. So I did. And I really did it because I thought, well, I want to have a plan. Like if I'm half busy with spine and half busy with general, I'm busy and I'm successful. And then when I got out, I realized you can't be good at everything. And so after about a year and a half, I got busy enough to where I quit doing any general orthopedic surgery.
It's incredible. There aren't many people that come out that say, yeah, the spine patients don't bother me. That's usually the problem, right? Is that, and especially when you look back 25 years ago, we didn't have what we have on the market right now, right? I mean, you look back at the first disc replacement that was approved, lumbar disc replacement, was 2004, 2005. Like, you didn't have any of those available when you were trained. Like, talk about your training a little bit and what was available, because motion preservation wasn't around in big numbers, and there certainly wasn't disc replacements around when you started.
There wasn't. So when I was getting done with my fellowship, there's always things that kind of come and go. Probably the one thing that came that's still here is in fellowship doing minimally invasive decompressions, where instead of making bigger open incisions, you use a series of tubes. And I remember doing that during fellowship, and that was sort of the latest and greatest. And then people were doing spine fusions through tubes. So it really was one of, we're still doing fusions, but we're doing less tissue trauma to do it. So hopefully we have less postoperative pain, faster recovery, things like that. But motion preservation surgery was not doing a fusion.
That's exactly right.
Yeah.
That's exactly right. So,
Not surgery.
no, that's
Yeah.
exactly right. So when did that spur for you? What was your initial interest in motion preserving surgery? Because you even talk about like going through hips and knees, patients are happy, right?
Yes.
I mean, you didn't see that in spine patients 25 years ago. We still struggle with that with spine patients now, and we're still going through that curve. But what was it that sparked your initial interest in motion preservation?
So if we're talking about my life story, what really motivated me, because I categorize people that do cervical disc replacement as either non-adopters, that they don't do them, light adopters, where there are cases where, if you think of it, once you've gotten to the front of the spine and you've taken out this disc, you have this void that has to be filled. But you also went there for a reason. And it might've been that there was a disc herniation. So taking out a soft piece of disc from around the nerves is, from a technical point of view, relatively simple. Whereas if somebody has really big bone spurs nearing the foramen or the side tunnels where the nerves go out, that is a much more technically difficult surgery. So what I find is the light adopters will do the simpler cases, and they're happy doing them. But if someone has a really collapsed disc or they have really bad stenosis, they won't do it, or they'll tell the patient you're not a candidate for it, which I disagree with, but there's that. And then there's a number of us that are the heavy adopters that, unless there's a contraindication to doing the disc replacement, we're going to do it, try to do a disc replacement. And so for me, this is what made things kind of crazy. About 12 years ago, I woke up one day, and I haven't really had a history of neck issues. I woke up, my neck hurts. I'm like, I can't move. And I'm like, grab my head and get myself up. And I took some oral steroids, and pain kind of went down. And then for the next 6 weeks, every time I would look up, my arm would go numb. So I wouldn't actually look up. I'd be leaning forward, looking up at an MRI on screen. I'd be like, I'd forget every time. I'm like, idiot, what are you doing? But it was funny. It wasn't severe. And I was pretty sure I had a disc herniation. But it was like, it's kind of getting better. A lot of these do get better. I stayed on ibuprofen, and 6 weeks it went away. So I was like, and it's not hard for me to get an MRI. I didn't even get an MRI. So I'm going along, I got better. And then 6 months later, I'm working out one morning. And then an hour later, if I didn't keep my neck flexed down, it would feel like someone put a tourniquet on my arm. And so I still remember I went to work, I had clinics. I walked around clinic talking to my patients like this.
So you need a spine surgeon,
Yeah,
doc.
I know. So I went to my team, and I was like, I need an MRI. So they scheduled an MRI for the next morning. We're surgeons are weird people, okay, but humor me. So the next day, I remember I had a surgery at my surgery center. And the funny thing is, to drive there, I had to drive like a lowrider, because I had to keep my neck flexed. But I could operate without a problem, because I operate with my neck bent forward. I'm asymptomatic. If I had any symptoms, I would have canceled the surgery. But and it was a younger patient. I still remember talking to her and her parents, and when I'm shaking their hand, my arm's going numb, and then I walk away and I get comfortable and I get her taken care of. So I do my surgery. I drive over to the MRI center. I get my MRI, and a lot of times people are hurting when they're in the MRI. That's why they're there. And if you move while you're in the MRI, you're going to blur the pictures. And so blurry pictures are terrible because I can't see what I need to see as a surgeon. So I'm laying there, I'm pretty uncomfortable, and I hear this, Dr. Rutz, quit moving in the MRI. It's like, oh. And so I get it done. I'm walking out. This is back when we had films, okay? It's more on CD-ROM. And I pull out my films and I look at it. I'm like, ugh, these are the ones that usually do bad without surgery. And then I get a phone call from my radiologist, and he goes, he's the guy that does a lot of injections for me. And he literally called me as I'm in the parking lot. He says, Kevin, this isn't going to do well with injection. So I was like, okay. So I go back to my surgery center, and I happen to work with a guy named Matt Gornett. If I've done 2,000, he's done 4,000 or 5,000 disc replacements. He's highly published, very much, lots of experience, and he's been a friend for a while. And so he's operating. So I take my films. I walked in his OR while he's scrubbed in. I put up my films. He looks at me like, all right. He looks and says, well, what do you want to do? So I want to get it fixed. He said, when do you want to do it? I go, today. And he goes, go talk to anesthesia. 3 hours later, he had me on the table. I went home that night. So that was Friday. I had my surgery. I went back to work on Monday. And then on Wednesday, I operated about 8 hours straight. I was just taking ibuprofen, and I wasn't being tough. It wasn't like I'm like in all this pain and I got to get these cases done. It's like, no, I was like, it's almost like having a bad cold. My throat was a little sore, kind of tight and achy, but I was not. So before that time period, I'd attempted to do several disc replacements, but I couldn't get them approved by insurance. Mm-hmm. And it was almost at that exact same time when there was a flip with insurance companies to where they were starting to pay for it. So now I'm sitting there going like, wow, this really worked well for me. Like, I'm gonna get more interested in it. And I also had the benefit compared to a lot of people of, so Dr. Gornett, I would see him like every other Friday. So if I'd see a case and I wasn't quite sure what to do, I'd just be like, hey, Matt, can you tell me, like, what would you do if I'm having any issues with a patient? He could give me advice. And most people don't have an expert cervical disc replacement person, that's a friend that's available and more than happy to teach and help. So those things really kind of pushed me forward with it. And so I kind of had to figure out how to do, over the years, what cases I could do well. And so at this point, probably 70% of my neck cases are disc replacements instead of fusions, whereas, 15 years ago, they were 100% fusions.
It's unfortunately a story we've heard multiple times of spine surgeons saying, I had to get spine surgery. Mm-hmm. And the perspective that gave them, it really allows you to sit in your patient's seat and think about, what would I want to do? And you want motion, right? So I'm curious, like, did your mind even go to fusion, or were you like, I want to figure out how I can get a disc replacement?
It's funny. In that moment, I didn't care. If Dr. Gornett said, no, I think we can do a fusion, I'd been like, thumbs up. Let's just take care of this, because I'm not a happy camper. And I think, when patients are really hurting, they'll sign up for anything. I had a former partner that he did sports medicine orthopedics, and he said, I used to have these patients come in that would have some back pain, and he was like, whatever, until he blew out a disc in his back, and his attitude profoundly changed. Now he's super compassionate about it. And so, your own experience. But the flip side, and this is where I get in trouble. I'm lucky. I have a team of people, a PA and nurse practitioner, that are very smart, very hardworking. And you need people to speak into your life, because sometimes, we can be foolish ourselves, right? We need advisors and other people that can be honest with us. And so I laugh. If I tell my story to my patients, they're all going to expect to be able to operate and do whatever in 5 days. Well, not everyone's that quick or that fast, and it seems like 25% of patients are kind of like that, like it's a magic surgery. And then 50% of people are just kind of normal, like they're off their pain pills in a couple of days, but you see them at 2 weeks and they're still sore, and, and it can take a while. But my nurse practitioner warns me, like, don't don't tell them your story, or else they're going to think they're going to be just like you. And if they're not, they're going to be mad. And it's like, you're right. So it's fun to be able to explain that I'm recommending for you what I recommended for myself.
Yourself. Yeah.
Do you think that, to Courtney's point, do you think that changed your perspective on just like, even just the providing care spectrum, on being on the other side of the table? It's interesting. Legitimately, I think 3 of the 4 last surgeons we've had on have all had spine surgeries themselves. And they talk about how it changes their perspective on how they go into it.
So one thing is, if someone said, why did you jump into surgery so quickly? And obviously it's my surgery center, it's my buddy, it's our place. You know, I didn't get insurance approval. They just took care of me. Okay. That's not normal, by the way, but that's, you know, if I, you know, did roofing for a living and my roof went out, I could call my company to fix my roof. Okay. This is the perk, right?
Yeah.
I don't tend to be a real anxious person. I knew the anesthesiologist. I have an extremely good surgeon doing the surgery. I knew the team of people there. I knew the operation. So my anxiety factor was kind of not there. And that's not normal for regular patients, you know? And so I do tell them the story from a perspective of knowing what I know, doing what I do. I wasn't anxious when I had to have this done, which is hopefully encouraging to them, because I mean, people read things online or hear stories from friends and about nightmares. So then when it's time for surgery, some of them can be scared to death, you know? And it's like, we have to respect that there's risks, but by the same token, you know, when it was my neck on the line, I wasn't afraid like you're afraid right now.
What do you say to patients that are on that line, right? Where they're anxious, they have this upcoming surgery, maybe they've never been operated on before, or they were told they need a fusion and now they're looking at motion preserving alternatives or disc replacements. What would you tell them in terms of kind of easing that anxiety, or just giving them a better knowledge base before they're going into surgery?
Usually what's helpful is kind of, where's their fear coming from? Half the time it's because they had a family member have a surgery that went poorly. Those people are scared to death, and you can encourage them, you can explain it, but that is a huge fear to overcome. The flip side is if I did a surgery on somebody and they were like one of my best patients ever, and then they send their buddy, I have to explain to their buddy, like, you might not be the best patient I ever had, like your friend was. There's those sorts of things. But where their fear is coming from, I think, is important. If you can figure that out. And then it also is trying to give them facts to worry about as opposed to something else. Like my favorite is, I'm afraid I won't wake up from anesthesia. In my 22 years, I've never had a patient not wake up from anesthesia, ever. That stuff, my dad, being an anesthesiologist from back in the day, anesthesia was super dangerous back in the day. Now it's like one of the safest things we do. And I don't even sit and worry a lot about someone in their mid 80s because they got $1 million monitoring machine. The drugs are really good. So that's an old fear that I don't even think about. But when it comes up, I'll obviously discuss it with the patient.
I think the other aspect too is, I think a lot of patients, to your point, is they know someone that got surgery, but the surgery that they got done was 40 or 50 years ago, right? And so when you see your dad or your grandpa or someone sitting in a rocking chair for 20 years because they can't move and they have a 5-level T10 to pelvis fusion, right? It's not what we're doing anymore, right? Outside of tumor, trauma, deformity, those instances, that's not the same technology and the capabilities that we have today, right? And so that's a different fear as well.
Well, it's funny. I remember this one patient, he was an older guy and he'd had a lumbar fusion 40 years ago. And back then, big incisions, lots of blood loss. They'd take a big chunk of bone from your pelvis. They'd pack bone on the back of your spine, put you in a brace for 6 months, and about 2/3 of people healed. So that's terrible. So I remember telling him, I'm like, okay, so we're going to do your surgery. And, the next day you're going to get up and walk and pee and go home. And he looks at me like I'm insane. I'm like, no, like we do that. That's normal. Like, you can do that. And that was fun because when he realized like, oh, pain control's better. We have better implants. I'm not taking bone from your pelvis. Like all these updates over the last 40 years. That's fun because he was a really happy patient.
That's a better story.
Yeah.
Right? That's a better story. There's one thing that I would like you to talk about too, because you do so many of these, is to truthfully go to a high level right now for patients that are hearing about this for the first time. Could you just delineate, we're talking about lumbar disc replacement and cervical disc replacement, but could you delineate for cervical cases, right? Neck cases, the difference between a disc replacement and an ACDF and getting a fusion, and then some of those subcategories of how you're treating those patients differently, right? But just what those two categories involve.
Okay. When in comparing a disc replacement to a fusion, obviously when we do a fusion, the goal is to make the bones grow together. We get rid of pain with that surgery, but we lose some range of motion. With a cervical disc replacement, the goal is to maintain the range of motion. When I do a cervical fusion, I restrict my patients for 6 to 8 weeks, basically saying no lifting over 20, 30 pounds, and don't be stretching your neck out. I'm not a big put people in a brace doctor. I know a lot of doctors still do that with cervical fusions. I hate bracing. I mean, let me put it this way, patients hate bracing. So I generally haven't ever done that. When it comes to cervical disc replacement, the other thing I've learned, and even the people that do a lot of it have different philosophies. So when I first started, I would go to courses and ask doctors, what do you do after the surgery? What are your protocols? And all of a sudden I realized they were all over the place. I had some that were doing soft collars for 2 weeks. I had others that were lifting restrictions for a big chunk of time. And a lot of times people would figure out the restrictions based on some sort of complication they had had. And ultimately, I kind of realized, at least for my patients, I tell them for a couple of days after surgery, don't do anything where you're hulking out, where your veins are popping out. And that's just so they don't have a bleed or something on the inside. After that, I think if you do a disc replacement properly, you can let them do whatever they want to do as far as lifting and working out and things like that. Because I think if it's done properly, I don't think they can mess it up. This is not a philosophy held by most surgeons. Most people do restrictions, and I'm aware of that. But to put my money where my mouth is, I had an opportunity at my kid's school. There's one of my son's friends is a dad who's a radiologist, crazy smart guy, and used to be a football player. He's 6'5", giant dude, and he works out, and he's super fit. We ended up doing a 2-level disc replacement on him. And he was like, can I work out? I'm like, yeah, give it 3 days. You can work out. And I know his wife, and it's really funny because he's a tough dude and she's so kind and sensitive. And she'd be like, he's hurting. And he's like, no, I'm fine. Because he'd rather work out and be a little bit sore. But I knew he was going to do a lot of stuff. And there's no way in the world I want my friend to damage himself with a post-op protocol. So that's just been my experience. There's a lot of rules I follow in surgery that I think some guys do a little bit different, why they see some things. But that's my philosophy, and I'm sticking with it because it's working for me right now.
And talk about implant selection too, because for cervical disc, lumbar disc, we've got one disc that's on the market right now, right? We've got ProDisc. Activell is no longer on the market, so we have one option. But in the cervical spine, tons of different options. You've got fixed core, you've got mobile core. How do you go about, one, how do you go about choosing the right implant? And two, talk about what you were talking about earlier, which is the importance of finding someone that's high volume for the purpose of they know what implant to use in what situation, because that's really important.
Yes. So the first implant I did was Mobi-C. The only reason I know the number that I did is because my reps told me. And we did that for several years. And it was around 400 or 500 implants we did. And then because I haven't moved or gone anywhere, if they're having problems, they come back. So I would say it seemed like 95% of those patients did really well. And the ones that but there was a subcategory of patients, and I call it the long neck skinny females. Where if you think of the people where they can bend their elbows backwards, really loose ligaments.
I was just going to say, you found the right person.
Don't have a Mobi-C. And it's not that every girl was like that, but there were a chunk of people where you'd bend them forward and backwards on x-ray, and we call it hypermobility. Like they're moving so much, it's making me nervous. I never saw that once with a dude. It was always long, skinny neck girls as its own category. So then the next one I went to was the ProDisc. They call it Legacy now. I really like that implant. They have updated versions of it. It's a more technically demanding to put in. That's the one thing I don't like about it. Like, you're spending more time with retraction on the neck and everything else. But once you get it in, I think it's fantastic. There was one called the M6, which has been taken off the market. And the problem was a certain percentage of patients, the implant actually mechanically failed, meaning that it was super complicated on the inside. And if one little part broke, then the whole thing kind of fell apart. And so that was figured out. And so that's why it's gone. The next one was called Simplify, which I did that for probably about a year and a half. And well, the selling point of it was when they did to get these implants to market, they have to do testing in a lab. So let's say in a lifetime, I might turn my head and look up and down 10 million times. So what they do is they take the implant, put it in a liquid, kind of like our own normal plasma, and they load it with 10 pounds, kind of like our head weighs 10 pounds. And then over 3 or 4 months, they just move it. And then at the end of that, they look and see how much did it wear out, how many wear particles are, did it last, did it fall apart? And so I remember the Simplify one had very good wear data. It is made out of a plastic and titanium and a ceramic core, which it's the only implant that does not mess up an MRI at all. So if you want to get a picture later, you can get MRIs on all the patients with all the implants. But like if you have a Pro Disc, it's a big piece of cobalt chrome. So it's going to blur the picture for several millimeters around the implant. So if you want to see where you just operated, you can't see it. So with all that data, I thought this is really great. So I did it for a while. I'm kind of stopped using that one. I had a couple patients with mechanical failures of that implant, which I never really expected. And then I see a little bit more, we call osteolysis, where, you do your surgery, everything went great. And then you're seeing people years later, and it looks like some of the bone is getting chewed on. And most of the time it's fine. It's not uncommon to see some osteolysis, even in a normal recovery and someone that's totally fine. And sometimes that's bone remodeling around the implant. But I saw enough of it to where I was like, I think that there's better options out there. And because I had those 2 mechanical failures, I'm like, no implant should ever fail mechanically. It can wear out in 30 years or whatever, that's fine, and it shouldn't, but that's fine, but not a mechanical failure. So now I use 2 different implants. I use Prestige LP by Medtronic, and I use the Pro Disc series. Their newer versions have the same mechanical properties. They're just easier to put in. And if you're doing larger, longer surgeries, having an implant that you can put in efficiently is helpful.
I think your story highlights 2 things that are just so important. And one of them is, as you go through the continuum of the cervical disc that you've used, you know why things fail and why they don't. And then you can select the right discs and the right technologies for the right patients, right? Because every pathology is different. It's funny when you go online to these forums, a lot of times you'll see like, oh, well, so-and-so had this disc and it failed. That means nothing for the next person, right? Because their pathology might be different and their disc might be different. So finding someone that has that, specialty where they do high volume is very, very important. And then the second part is, I think, the importance of having different options, right? And that's one place that technology is advanced, right? Like you have mobile cores, you have places where you're not going to get artifact in your MRI. And that's important to be able to cycle through those and choose different options when you need them.
I think so.
One other thing that you talked about earlier that I'd love to touch on, you said about 70% of your patients are motion preserving and about 30% are fusion. I think that's a pretty good breakdown, right? I mean, there's always going to be tumor, trauma, deformity, right? I'm sure you get people that come to you for second opinions, right? So some other surgeon told me I need a fusion and I'm going to come and get another opinion. What percent of those patients do you think that come to you and we're told they need a fusion, could you put in a motion preserving device on, or could be motion preserving candidates?
I'd probably still say 70%.
70%.
Yeah. And I think that what's interesting is if I take St. Louis. So in my practice, I do a lot of disc replacement, 1 or 2 level lumbar fusions, 1 or 2 level lumbar disc replacements. I'm not doing the big stuff. I'm not doing tumors. I'm not doing scoliosis. I trained in those things a long time ago, but in private practice, that just doesn't walk through the door all the time. And you can't be good at it unless you do it regularly. So what do I do when someone comes in and I find those things? I have buddies. And in this town, there are guys downtown that are amazing. And I take my phone and I'll shoot some pictures of their MRIs and x-rays and text them and say, can I get them in? And they'll be like, I'll get them in. And they are, I respect them and I'm glad they're there. So I was laughing. I had dinner with one of these guys a year and a half ago, and we're talking about things, and I'm talking about disc replacement. He's like, I'm sitting here doing a couple thousand of them. He'd done like 5. And this is the guy I refer to for complicated cases. Okay. So if you're only doing a few a year, then you're probably only doing the easy indication surgeries. The flip side is when I look back if I look at a given year, like let's say I did 100 neck surgeries, the indication for the surgery was 80% of the time it's stenosis or the narrowed bony nerve tunnels, which is the one that's the hard one. And the big soft disc herniation, so many of those people get better without surgery. They come in, they're miserable, you send them for some shots. The natural history of a soft disc herniation a lot of the times is to get better without surgery. Whereas the bony stenosis, they have a structural problem there. And sometimes with non-operative care, things calm down and the nerves adapt. But when they get to the point that that's not working, if you go to people that don't do a lot of disc replacement, they're going to recommend a fusion. And frankly, if you're going to have surgery with them, you probably should have that, because I've seen cases where people got their disc replacement, but they didn't have an adequate nerve decompression. And so the patient was like, why am I not better? I'm like, well, if he fused you, you would be okay, because you actually don't have to do a good decompression with the fusion. Once you take away that motion, that protects the nerve and people can be happy. And I don't think I really did great decompressions until I started doing disc replacement, because I'm like, why should I do the more dangerous, like I take out some bone spurs, but I just jack that space open. I keep my surgery shorter. It's not going to change my outcome. And avoid dangerous things on people. Doing a good nerve decompression, you have to get closer to the nerve and be touching it and doing things. So I'm definitely better at decompressing nerves now than I was, 15 years ago by far.
Because you know the importance of it, right? Like if you can get an indirect decompression by getting a cage large enough and cranking open the space, right? Yeah. But when you've got motion, you have to clear everything out.
That's right.
But that's a lot of it, right? Is like if you're not going to someone who does high volume, you don't know about that, right? You're like, oh, I can put this same motion device in this patient, not do the same decompression or the same prep, and have the same outcome. We know they're more specific.
It also makes me go back to something you said earlier, which I think is a really good point, speaking to patients. And it's, when I asked you, like, did you think about a fusion? And you were like, when I was in that pain, I just wanted it to get fixed.
Yeah. And
so many patients are at that point, right? For one reason is I'm avoiding surgery as long as possible because there's a bad rap around, spine surgery.
Yeah.
But then you just go to who's closest to you a lot of times. And if you don't know that there's other options and you're told you just need a fusion, there's still this story of the patient after, of what is that, the cascading effect if I get a fusion versus if I was to get something motion preserving like a disc replacement. And so I think that's another point I'd love for you to talk about, of what you've seen in your practice of the impact of getting a disc replacement versus a fusion, and the adjacent levels. How is that being impacted? And for patients, the importance for them to understand the dynamics of all of that. So when they're going to their doctor and they're just given the option of a fusion and they're like, I'm in so much pain, like it's worth it for maybe just looking for another second opinion of someone who is able to do a disc replacement and see if you're a candidate for that.
Well, you're speaking my language, of course. It's kind of funny. One of the big reasons we're doing a disc replacement is we're hoping to not create a stress riser that we fix the problem, but did we create a new problem by making something stiff and accelerating wearing out above and below? And it's interesting. there are a huge amount of cervical disc replacement studies. And in some of them, they say no difference in comparing a fusion to a disc replacement. Some say there are. And so theoretically, mechanically, I think the farther out we get, we should be seeing that more and more, and it'd be less controversial. But I remember the first one, I read a study where it said there was no difference. I was like, really? Like, I don't believe it. And then you read another one. What the flip side of that, though, is lumbar disc replacement. The data is very good. So at the 7-year, I don't know how much all people understand what FDA trials are like. And sometimes in the news, the FDA gets a bad rap. But and I think even the medical industry gets frustrated with the FDA. But these are not evil people. They're trying to protect people. So when something comes out, like a lumbar disc replacement, you have to go through these trials. And an FDA trial is super expensive to do. And the way it works, they pick the device and then what they're going to compare it to. So they're going to compare a lumbar disc replacement to a lumbar fusion. They did a randomized control study, meaning if you're a patient that signed up for it, you're going to go to sleep and you don't know what you're going to get. Okay. And then they said, well, we're not going to just have one surgeon do it. We're going to have 10 centers around the country, 10 different surgeons, 15, however, and they're all going to follow the same protocol. And then when we get the results, you're blinded to it. So like, you don't know. And so it's as clean a study as you can do. And then they follow these people for year after year after year. And the 7-year outcome data for the lumbar disc replacement was amazing, though, because what they showed was if you got a 2-level disc replacement compared to a 2-level fusion, the fused patients were 300% more likely to develop another problem. Not 30%, not 100%, 300%. And so, and that's level 1 data. That's the best data we have. And so for me, that's very compelling. The other, since I get to tell stories and I think it's kind of fun how we get to where we're at, I got into lumbar disc replacement later than cervical because I told you I was freaked out by complications. And so I'm sitting here in my office and I had a patient with 2-level degenerative disc disease. And I was like, I think a fusion will help him. So I applied to get my surgery approved, and it was actually United Healthcare. Okay. And they denied it. And I was like, okay, so we'll do our appeal. So we appealed it. They denied it. So let's do the external appeal. I did my external appeal, and this is a whole dog and pony show that takes months. And,
while the patient's still in pain,
right.
dealing with it.
Oh, it happens all the time. And so what's funny is a lot of times we'll do what's called a peer-to-peer. Well, the insurance company hires a surgeon as to review the case, and then I get to talk shop with them on the phone. And the way the game works is the first peer-to-peer is based on their policy. And so I'm talking to another surgeon, and most of these guys are like, they just retired and they're looking just to make a little money. And it's kind of fun because you get some pretty bright guys. And they'll say, look, this is a policy level review. UHC policy says we don't pay for 2-level fusion for degenerated discs.
You mean disc?
No.
Oh,
fusions,
no, fusion?
This is my backstory. This is the backstory. And so I'm like, well, should I do an appeal? And it's like, yes, you should do an appeal. So I do my appeal. And then that gets denied. And then there's a final appeal or a situation. So I get to this last peer-to-peer situation, and I'm talking to this surgeon. And he goes, I'll tell you what, that appeal, he can make a decision outside of policy. He can actually say what he thinks is best for the patient. And this is a guy that's done spine surgery for years. He says, Kevin, I'm not going to approve a 2-level fusion for you, but I would approve a 2-level lumbar disc replacement. And I go, no way, because no one's approving that. And I haven't done any. And I was just shocked because that never happens. And so 6 months later, I had the exact same conversation on a different patient with another UHC reviewer, okay? And after that, I started thinking like, I'm young enough, I'm going to be doing this for a while. I probably need to get trained and figure this out. So I went and got trained and then been doing them for several years now. Here's the irony. UHC's policy is still the exact same. And since then, I've had patients I've asked for 2-level lumbar disc replacement, and every reviewer I've ever got has always turned it down. I've never gotten the same lucky scenario. But anyways, I thank UHC for motivating me to become a better surgeon. Now let me take care of your patients.
Wow. That is crazy. But that's also one of those, sometimes I feel like those moments just happen. Like if that wouldn't have happened, who knows how much longer you would have gone before you decided to do this. But what a difference it's made for your patients moving forward.
Big time.
Still the frustration of the insurance daily, but that's an incredible story.
Thank you.
That's crazy.
It seems like surgeons tend to really like the peer-to-peer situation. Seem to really like that. Really enjoyable.
It's funny though, because in the, I probably do 3 or 4 peer-to-peers a week. I mean, it's just part of the business. And especially if you're doing disc replacement, because if you're trying to do like if you have a patient that needs a fusion here and a disc replacement here, you can do them both during the same surgery. If I was a patient, I'm like, I don't want to be cut open twice. But I also don't want a big long fusion. So just fuse what you can only fix by fusing and then do disc replacements elsewhere. They call that a hybrid. And there's one insurance company that'll pay for it. And it's, which is Aetna actually. No other insurance company will pay for a hybrid as it's against their policy. And so sometimes you can get it turned over on secondary appeals. But I've had patients where I said to them, look, your insurance company they'll pay for the disc replacement, and then later they'll pay for a fusion, but they won't pay for it at the same time. And I'll dictate a letter explaining how this is going to cost the insurance company more money, put the patient at more risk, all this stuff. And every once in a while I'll get it flipped, but they still like feet in the sand. And there's no data to show hybrids don't work. And there's people doing hybrids all the time. And when you go to a conference and hear surgeons talk, they're kind of like, what's the big deal? This works.
But it's an easy way to find a denial, right? Like, we don't have to pay for that. That's a really easy way to say we don't have to pay for that.
Well, back in the day when we would do peer-to-peers, it's a physician. I'm like, okay, what's your specialty? Well, I'm a pediatrician. Like, really? Like, I wouldn't tell you how to take care of children. You shouldn't tell me how to do spine surgery. Gratefully, over the last several years, it's almost always a neuro or a spine surgeon I'm talking to, which is good.
Seems more reasonable.
It is. Oh my God.
It is. I love that you bring up the concept of essentially you're following the data, right? I mean, we have so much data. You could argue that lumbar motion preservation, especially disc, is probably one of the most studied aspects that we've seen in spine, right? There's just a paper released, 20-year follow-up, 2,100 patients. Average follow-up was about 7 years, 1% revision rate, like incredible data, yet there are hurdles to adoption, right? So it's exciting because we know motion preservation in the lumbar spine works. And it makes sense because you've got higher biomechanical loads, right? You've got bigger force loading, you've got more shear, you have all these different aspects. So it makes sense that motion works. And now in recent years, you had, TOPS, a facet replacement that came on. We know about MODIS, lumbar total joint replacement, which just went through clinical studies, is still gathering data. But there's going to be more options, but we see that these are good alternatives, right? Instead of going and getting a fusion done.
Well, and the thing that makes me crazy now, I'm just going to whine. It's a podcast. I'm just going to whine and complain about what I'm unhappy about in the world of insurance, right?
We're in the therapy chairs.
That's right. So when you want to do something that's outside of the FDA trial study technique, so the insurance company said, we will approve it if you only do it just like the FDA study. And the FDA study said they can't have ever had any surgery before. You can't, be over this many years old or whatever. Well, that makes sense for a study, but not for application in the real world. My job is to look at the data from the FDA study and then apply that to the characteristics of my patient. So the lumbar disc replacements were done in people from 18 to 60. So if you're 61, your insurance company will not pay for your lumbar disc replacement. And I laugh because I have 50-year-olds that have the bodies of 70-year-olds. And then I got tons of people that, they're in their 60s, maybe early 70s, and they run, they lift, they're in fantastic shape. And their bone density is good. I'm like, you're as good a disc replacement candidate as there is. You just weren't in the FDA guidelines, so your insurance company won't pay for it. And I laugh. I used to think Medicare, they generally you don't require a lot of prior auth. You could kind of take care of your patients like you wanted to. They had looser guidelines. So I had a mid-60s gal who was like an aerobics queen type person. So we did her disc replacement and she did really well. And then later I found out, well, you're not going to get paid for that because Medicare had that guideline and I didn't know it. So I kind of learned the hard way, but it's interesting. So I laugh as I'm getting older. I'm like, oh boy, I guess I might not be a candidate one day. Hopefully things will change.
So what you're talking about too, for patients listening, is off-label usage of devices.
Yes.
Correct. And so I want to highlight this too, because I think it can be a scary term or sound scary when it's your surgeon wants to use this off-label and therefore or it's medically unnecessary, right? You get all these terms when you get denials. But even you're talking about hybrids, there's no reason that a motion construct next to a fusion wouldn't work. We already know a single level case works, right? And when we had single level approval, we had approval that the device works and it's safe and it's effective. But if you did a 2-level, now it's all of a sudden off-label and now it's not safe. And now we have 2-level approval, right? But now a 3-level isn't. And so all these little nuances, I think for patients, I think it's an important point because that term off-label can sometimes be scary. And what is my surgeon trying to do? But it's really just a nuance of a word.
It is. And I think it's funny, depending on what your patient mix is, there's certain situations, like if you're taking care of a workers' compensation patient, there's not these same guidelines. Medicare doesn't have the same guidelines. So the significant volume of patients, maybe a third of them, have a different payer that I'm not dealing with guidelines. So I can do what I want to do. And so I have people where we've done 3 and 4 level disc replacement. It works. And I think, as I talk with some of my friends like Dr. Gornett and some of these others that have high volume, we talk about the pros and cons of different implants, too much mobility, too little, maybe a little more constrained device is better if you're doing multiple levels, and kind of that theoretical things. But I have no evidence so far that doing a 3 or 4 level doesn't work just as well as a 1 or 2 level. I think the other thing that's interesting, maybe a little controversial, would be can you do a disc replacement to help neck pain? And for those, if you're not in the spine world, the general indication for doing a neck surgery is because you're pinching a nerve with pain down your arm. Unless you're talking about a tumor or something weird like that, but the day-to-day stuff is you're trying to treat nerve compression. And so if it's mainly neck pain, kind of train like you do therapy, you get shots, but don't do surgery for neck pain. But the funny thing is we have people that come to us that have a disc herniation with neck and arm pain. We do their surgery, whether it was a fusion or disc replacement, and guess what? The neck pain got better too. So I think there's some movement of people trying to figure out to what degree can we take patients with pain just from a disc wearing out and improve their neck pain. And I believe it's very possible because in my practice, we see that all the time. But that would be considered controversial. Sometimes insurance companies don't want to pay for it because they say, well, they don't have a pinched nerve. So surgery's not medically necessary, and it's like, I hate that. It's like not like I'm a crazy butcher, not necessary. Okay. I just made it up, but I see that all the time. Patients kind of figure it out though.
Yeah. And it's funny too, when you get told, from an insurance provider that is not medically necessary. It's like, oh, sorry, I've been working for 25 years. I watch all my patients. I've done 2,000 of these. Yeah. And I'm going to have someone outside of that realm, especially if it's not a spine surgeon, tell me this isn't medically net. That is insane. It's crazy. But patients don't see a lot of that side, right? So I think it's important to open up that aperture and let them know, like, there are other aspects at play in what's provided, what your insurance will cover, outside of just what you would like to do or what data shows that works.
Yep.
So I'm curious because you've done so many of these. You've been, in practice for 25 years. If you could dispel one fallacy for patients that come through, what would that be in terms of knowledge coming in, what they hear, possibly fears that they have? If there's a fallacy that you could dispel around spine surgery, on specific things that you do, what's something that you'd like to dispel in terms of knowledge?
I really like them to know, at least think of things from my perspective as compared to theirs. So like we were talking about, the patients that are afraid of anesthesia, you can be fear of getting nauseated because that's a real thing, but fear of death is almost irrational. When it comes to certain pathologies and certain treatments that have such a known track record, to me, we knew this for 20 years. To them, they've never heard this before. Mm-hmm. So I have a story. So there was this lady who was had some problems with her back and was starting to get some pain in her leg. And she was a little bit older. And she went on a walk down the street, and she got partway there, and then her leg was hurting really bad. So she kind of sat down on the side of the road, and this man went up to her and said, "Ma'am, would you like a ride home?" She says, "Yes, I would." And so that kind gentleman, the lady home, and she got in the house. The next day, I find out that while I'm video chatting with my mom, that it was her. That was the patient. So then I'm like, "Mom, what are you doing?" And I knew she had a problem in her back. And she had a situation that's very common where one bone slips on another bone. It's the most common reason we do a spine fusion. And so she's in Texas. I found a surgeon down there that I really liked. And so when my mom was 78, she had a spine fusion. Why did I tell my mom to do that? She's older. There's risk to the surgery per se. Well, the relative risk was very, very low. And the likelihood of her getting better without it was terrible. And she had her surgery and she's fine. So I want people to, like, when I'm recommending this for my mom, it's because that's how confident I am is when we do things right, it should really go well. One of the more neurotic cases for me was doing a cervical disc replacement on my nurse practitioner. So my nurse practitioner is fantastic, and we do clinic together, surgery together. She'll see people without me. And so she developed a cervical radiculopathy, pain down her arm. We did shots, we did everything. It wasn't working. So we decided, she was like, "Well, I want a disc replacement," because she sees all our post-op patients, and she's like, "That's what I want." And I'm like, "Great. I get to operate on my friend, like stab your friend in the neck." And so we did her surgery and it went well. I remember we did her surgery on like Thursday or Friday. And then I was gonna be out of town the next week. And she sees patients in clinic for me when I'm not there. So what did I do when I had surgery? I went right back to work. I was like, "Lauren, you want me to cancel your clinic?" She goes, "No, I'll do my clinic on Monday." And I wasn't being the jerk boss, like making your person go back. It's like she knew she could because she knew herself, knew the surgery, knew the outcomes. Like, I know I can do this. I'm not worried about it. So that was, that's what I kind of want patients to know. And then when I tell a patient, like, you're not a good candidate, or this is risky, or you're at high risk for a complication, like, I'm not saying that to scare you. There's some surgeons that kind of make everything sound scary. I'm like, I'll have someone come in for a second opinion, and they tell me what the other surgeon said, and whether they're accurate or not, I don't know because I wasn't there. But I'm like, that's the speech I give when I think I might kill someone with a surgery. Like, this is an easy surgery, and they gave the scary speech, So I want them just like, if I'm telling you this is not ideal, I'm not lying. It's not that I don't like you. That's how I look at the situation.
I love that story about your mom and about the NP because they are procedures that you can actually promote and encourage because you've been through it before, right? That's the value of having a high volume practice and seeing all these different aspects is because you've been through it before. You've seen the outcomes, you've seen what it looks like. So you can tell patients when motion preservation might be the right option or when fusion might be the right option and what patients are going to do well with that. The question that I really like to ask you, this is a complex topic when you're going to get spine surgery and you're trying to get spine treatment. What questions should patients be asking when they're coming in? Because it's a difficult task. So when they're coming in and they're asking about motion preservation, what options they have available, what questions should they be asking?
So first, if they can spend some time if they can figure out what their diagnosis is and just understand the anatomy a little bit, I think that's helpful. Once you understand that, if you want a disc replacement versus a fusion, in my opinion, if the problem is primarily one of a pinched nerve, but the joints in the back of the spine are in good condition, the vast majority of those people are candidates for a disc replacement. And then if you're going to a surgeon that brings it up and says, "Hey, I think you're a candidate," well, then obviously he's interested. If you bring it up, then you can just ask, "How many of these do you do a year?" And if you're only doing 4 or 5 a year, then you say, "Well, do I have really bad arthritis in the back of my neck?" Well, if it is, then maybe you should get a fusion. But if they say, "No, it's not that bad," well, then you're you probably are a candidate for a disc replacement. You just haven't gone to a surgeon that is that dedicated to the craft in that area. So I think getting informed, getting second opinions, I think in almost every major city, there are guys like myself who picked this one little area of spine surgery and really made it a pet project. So when I go to conferences or we teach a course, they'll have other teachers, and they're all of a sudden I realize, quote, I found my people again. Like they're doing the same thing I'm doing. They went through the same learning curve I did, but they did it in California or Florida or somewhere else. And so if you're really interested in that technology, look for it. And then I'd also say a lot of the spine companies can help you find a surgeon. So Sentinel Spine, they have a website called Rediscover Your Life. They have what's called a surgeon locator, where you get on there and you can put your zip code and they can help you find people that have an interest in disc replacement.
It's so helpful finding the right people. And I love that stance too, what you alluded to earlier, which is when I'm not the right person for you, I'll help you find the right person, right? Because that's tough. That's tough to set aside. You're an operator, right? It's tough to set that aside and say, well, I could take care of this, but it's finding the people that do high volume in those other aspects. As we wrap here, you've been doing this for a long time. You've been in practice 20 years. What are you excited about? Because you still have plenty left in your career. You're pushing the bounds. You're doing motion preserving work. What are you excited about on what's on the horizon of spine and spine care, and what capabilities we'll have in the next 5 years, 10 years, 15 years down the road for patients?
So for me, I think it'll be interesting if there's a solution to things I have to do lumbar fusions for. So and I know very little about it right now. There's a new device that's coming where the patients that were always doing fusions on in the lumbar spine because of bad joint arthritis, they figured out a way to go in through the back, and you can basically replace the joints and the disc at the same time. When I first saw the thing in a journal article, I thought it was crazy, but the data that seems to be coming out from it seems very promising. And so someone a lot smarter than me invented this thing. So I think if it proves to be that good data to keep going forward, I think that's really interesting. And the other thing is, I remember the first time I did my first lumbar disc replacement, and everything else I'd done thousands of times. And so I remember I was neurotic just because I'm like, I picked the easiest patient, the easiest case, but I'm like, just worried I'm going to do any little wrong thing, And so you kind of go through your learning curve. It'll probably be the same thing when this comes out. I mean, if the data really holds true, I really think it is significant. And so then I'm going to have to man up and get trained, talk to a lot of people, and then pick the easy case to do first, and then pick up the technology.
And the device you're referring to is the Modus lumbar total joint replacement. And it's funny because I think a lot of people have that same reaction, not just that, because I had the same reaction when I saw it for the first time 7 years ago, right? Then you start to follow the clinical data and the studies behind it, right? And I think that goes for any new technology on the market, which is, at first it sounds crazy, right? I mean, we used to fuse knees and we used to fuse hips, and that was normal. Yeah. And then Sir John Charnley came around and said, we're going to do a hip replacement. I'm sure there's people that ostracized him and said, this guy is crazy for making a mobile joint, right? And that's with any new technology. And then you get a disc replacement, right? The Fernstrom ball 60 years ago. We were trying to do motion preservation 60 years ago. They just put a ball in between two vertebral bodies, right? And it sounds crazy when you first start, but then you follow the clinical data. I think it is really exciting. That's what we get excited about to talk about on here. When we're talking about disc replacement and facet replacement and joint replacement, we're just slowly moving the ball forward, right? Yeah. And giving more options to patients. We appreciate this. We went through a lot to get here too. We went through tornado. Yes, exactly. And we know you had a full day of operating. So we really appreciate you taking the time. The one thing I do want to do before we wrap here is, where can patients find you? For patients that are looking for you, where can patients go to find you?
So if they Google my name, Kevin Rutz, MD, orthopedic specialist, St. Louis, it'll pop up. We have a website called the Disc Replacement Center of St. Louis. So if you type that in, it'll pop up. Those are probably the two easiest ways. And then and my office is in St. Louis, Missouri, a subsection called Depair.
That's incredible. Well, we appreciate you taking all the time. You know, when you're doing 2,000 of these and you've done 2,000 of these over time, it's a little bit easier for patients to find you, but we always want to make sure that they can find you. So thank you so much for taking the time. This won't be the last time we sit down. Thank you so much, Dr. Rutz.
Thank you. Appreciate it.
Thank you.